Danny, there was hope, I think. It's important to bring this up about can we select, is there a biomarker to select? As we discussed earlier, there is no biomarker to select for it, the target agents. So there was hope that with nivolumab, and the anti-PD-1, anti-PD-L1, the immune checkpoint inhibitors, that we thought we had a biomarker with the PD-L1 expression. But what this phase 3 trial, Checkmate 025, showed is that the PD-L1 expression in tumor cells, whether you use a 1% cutoff or 5% cutoff, was not associated with the benefit. So we're back to the drawing board as to what is a biomarker for selection if you're going to select any patient for an immune checkpoint inhibitor. Right now, I do not think we have that. So any patient should be eligible to receive nivolumab. You cannot segregate based on a PD-L1 expression, yes, positive or negative.
But Nizar, correct me if I'm wrong, that these patients were tested in the initial tumor. And we know PD-L1 is a very dynamic marker.
Right.
So who cares what the PD-L1 is in the primary tumor? I do care for the PD-L1 status when I start in therapy.
But
okay,
but maybe
we
even that
lack that information
but
completely.
maybe that is even not informative, and then we're still stuck with the fact that we do not have...
But I think that's a difference between RCC and melanoma. Melanoma, you can biopsy the skin, and then that's fairly straightforward.
But the difference is the similarity is that we don't have a validated
we don't have the
predictive marker.
Yeah.
And even in lung cancer, where there's development of PD-L1 as expression as a biomarker, the reality is that it's become a cost-effectiveness enrichment tool. It's not an adequate clinical selection tool. So no clinician, in my view, should not treat somebody with lung cancer on the basis of whether or not they've got PD-L1 expression. Health economically, you can enrich a population of patients who are going to have a higher chance of benefit, but it's nowhere near good enough to be called a clinical predictive tool.
It's
And we really need to be wary
It's
about
not like the EGFR and using an EGFR inhibitor in lung cancer, or KRAS with colorectal cancer and the choice of the antibody against,
I'm not sure that when both cabozantinib and nivolumab are going to be approved by FDA, EMA, and all the other regulatory authorities, whether with the current hype around nivolumab, whether that is really going to be the winner, because we're going to overtreat 80% of patients, and we do not have a good selective marker. And it's an IV treatment, so it gives a lot of stress in your hospital. So of course, I'm extremely enthusiastic. I love the presentation. You love the publication. But I'm not really sure whether it's going to be implemented as easy as that. And then on top of that, of course, it's extremely costly. So if either the cost, the price doesn't go down, or we don't have another way of agreement with pharma to say you can only get reimbursement if the treatment proves to be effective in Mr. X or Mrs. Y. I'm not 100% sure that it's going to be that same hype and rush to treat all your patients with nivolumab in second line.
Danny, in the US, I've spoken to a lot of my colleagues, and we had a lot of ad boards in the US about choice of second line. Would it be nivolumab and cabozantinib? Where does axitinib? I agree with Paul. Everolimus is pushed down to the fifth line, and possibly axitinib also to the fourth line if cabozantinib is FDA approved pretty soon. But I agree with Susanne. I think cost is an important question, especially in countries where you don't have all the resources. So I think if the Meteor trial shows survival advantage, OS now is the second endpoint, and if it shows a significant survival difference between cabozantinib and everolimus, so then you're going to have a drug that has PFS advantage, OS advantage, response rate advantage. That's oral. That's going to be cheaper when you use an oral agent rather than bringing a patient every 2 weeks to the clinic for nivolumab. So I think even in the US, I would not be surprised if people went to cabozantinib as the salvage after the first line VEGF-R TKI instead of nivolumab. despite the exciting news about immune checkpoint inhibitors, because of convenience of an oral agent, and the cost is going to be less with an oral agent rather than doing the IV every 2 weeks.